Welcome to the 374th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today, I welcome Tom Ewing and Catherine Randall, co-authors of How Did We Get Here? What are droplets and aerosols, and how far do they go? A historical perspective on the transmission of respiratory infectious diseases. Just a reminder, you can usually catch COVID Calls live on weekdays at 6 p.m. Eastern Time. Just go to the COVID Calls YouTube channel to watch. You can also hear COVID Calls anytime, recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID Calls via Twitter using the handle @US of Disaster or @COVID Calls. Please help spread the word and send suggestions for future guests and future topics. And as always, please feel free to suggest yourself as a future guest. We are scheduling COVID calls now out to the end of 2021 and have received a number of great suggestions for future shows and guests to feature. So please do be in contact. As of today, November 9th, 2021, there are 5,056,189 deaths from COVID-19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. I've been reading an obituary or a story of advocacy for those impacted by the pandemic. I'd like to continue that now. This is a news piece from May 14th, 2020, which I'm reading today in part because I'm interested to hear my guest's perspective on it. The title is "Why Are There Almost No Memorials to the Flu of 1918?" This appeared in the New York Times by David Siegel. At Hope Cemetery in Bear, Vermont, a 5-ton granite bench sits on a triangle of grass. It's a mere 5 feet high and 3 feet deep, which seems modest in scale relative to the calamity it commemorates. 1918 Spanish Flu Memorial reads an inscription on the front. Over 50 million deaths worldwide is chiseled on the back. Installed 2 years ago, the bench was underwritten by Brian Zecchinelli and his wife Karen to mark the 100th anniversary of The Wayside, a restaurant they own in nearby Montpelier. It opened in 1918, just a few months before influenza scythed through the area, killing nearly 200 people, the largest loss of life of any town in the state. One of the dead was Mr. Zecchinelli's grandfather, Gemino, an Italian immigrant who worked as a craftsman in a local granite factory, one of many in a town that still bills itself as the granite capital of the world. Mr. Zecchinelli knew little about his grandfather's life, which lasted just 35 years, so he spent months researching his death. He quickly became fascinated not just by the flu, but by its near total disappearance from our collective memory. When I looked for memorials to the flu, I found nothing, he said. I mean, there was a plaque in Colorado, maybe something small in Australia, and that was it. I thought, this is crazy. This flu changed America forever. It changed the world forever. I've got to do something. Flu ravaged civilization for nearly 3 agonizing years on a scale that had not been seen since the bubonic plague wiped out at least 1/3 of Europe's population in the late Middle Ages. Some 675,000 Americans died, more than the United States casualties of all the wars of the 20th century combined. This article, again, was written in 2020. But soon after the slaughter ended, and for decades after, the pandemic somehow vanished from the public imagination. With rare exceptions, it didn't crop up in novels, paintings, plays, or movies. Even scholars overlooked the subject. The first major account of the flu, epidemic, and peace, later reissued as America's Forgotten Pandemic, was published in 1976 by Alfred Crosby, who was baffled by the absence of any impression left by the disaster. One searches for explanations for the odd fact that Americans took little notice of the pandemic, he wrote, and then quickly forgot whatever they did notice. Historians say the pandemic sank into oblivion largely because of World War I, the very cataclysm that hastened the spread of the virus via millions of moving troops. The war and its aftermath overshadowed the disease, too. For the Allies, there was a victory to celebrate in November 1918, and triumphalism was the mood of the era. By 1920, isolationism regained its pre-war popularity, and the flu was regarded as just another malignant foreign force, both in the United States and elsewhere. It remains a mystery where the pandemic began, but the historian Kenneth Davis notes that many countries tagged it with a name suggesting foreign origins. Germans called it the Russian pest, the Russians called it the Chinese fever, and in Spain, where virologists say it certainly did not begin, it was known as the Naples soldier. When the centenary of the outbreak rolled around 2 years ago, there were no anniversary events, said Nancy Bristow, author of American Pandemic, The Lost Worlds of the 1918 Influenza Epidemic. I was asked to give talks only at places that were discussing the war. Sort of, oh, this happened at the same time. Can you come talk about it? In Vermont, Mr. Zecchinelli decided he was uniquely situated to light a torch in this darkness. His grandfather and dozens of his colleagues perished, he learned, because Geminio worked in a poorly ventilated granite factory where he and others breathed in vast amounts of dust. A lung disease called silicosis was an occupational hazard and left them vulnerable to the influenza. More than 100 granite workers in Bear died in the span of 3 weeks in 1918. Health officials reported that the town ran out of caskets and used wicker baskets to transport the deceased. People were so terrified by the illness that a local florist found that grieving families had fled their homes, leaving the bodies of their loved ones behind. Volunteers are needed, wrote the local newspaper the day before Geminio died on October 10th in a plea for nurses. Will you respond? They wrote. The industry that contributed to Geminio's early demise would help valorize him. Brian Zecchinelli approached Rock of Ages, a granite factory in Bear, which did more than just help design and then build the memorial. Mr. Zecchinelli would not discuss dollar amounts, but he says that the company created a work worth 3 times as much as he paid. Markers for victims of the pandemic are just simple slabs, said Mr. Zecchinelli, offering a video tour via iPhone. They were burying people as fast as they could. About 100 people attended the unveiling of the memorial on October 28, 2018. It was a brisk and overcast day. 3 members of the clergy offered words of condolence and prayers in a ceremony that lasted less than an hour. It was a solemn, uplifting event, Mr. Zecchinelli said, and far more satisfying than any centenary idea he could have dreamed up for the Wayside, which, like every restaurant in Vermont, was closed for weeks at that time when the story appeared in 2020. But he said the restaurant survived one pandemic, and it will survive this one too. Okay, I'd like to turn to my discussion for today. Let me introduce my guests. Tom Ewing is a professor of history and associate dean at Virginia Tech. His current research projects include studies of influenza pandemics, including the 1889 to 1892 Russian flu and the 1918 to 1919 Spanish flu, and a history of Virginia's first tuberculosis sanatoria, Catawba and Piedmont, in collaboration with Catherine Randall and Kiana Wilkerson. In 2020, he worked with graduate students from Virginia Tech to understand the use of masks during the 1918 pandemic, which resulted in essays published in the Washington Post, Health Affairs blog, the Items series of the Social Science Research Council, and Nursing Clio. Catherine Randall is a visiting lecturer of technical communication at the University of Central Florida. Her most recent research projects include a rhetorical history of the scientific understanding around airborne transmission, and a history of Piedmont and Catawba tuberculosis sanatoria, and an exploration of the role of health communication in refugee resettlement in the United States. Catherine Randall and Tom Ewing, thanks so much for joining me on COVID Calls today.
Thank you.
Thanks for having us.
I'd like to start the way I generally do, just to get a sense of where you're calling from and what the pandemic situation looks like there. Catherine, can I start with you on that, please?
Yeah, absolutely. So I recently moved to Wilmington, North Carolina, from Blacksburg, Virginia. So I'm in Wilmington now. I have a first grader. So my view of the pandemic situation seems to always be filtered through the lens of school and what the schools are doing. We do have a mask mandate here. The school board right now is actually voting on whether or not to keep the mask mandate for the next month. And in the state of North Carolina, the law says that the school boards have to meet once a month to determine if they're going to keep the mask mandate. So that's our situation here. We do have a decline in cases, but we'll see what happens with the holidays.
Let me just ask you just a follow-up.
Yeah.
That mask mandate issue has become as heated as other parts of the country. I know that, obviously the press is going to follow school board meetings where people are yelling and screaming. That can't be everywhere, but is that in your town as well?
Yes, Wilmington is a very purple city politically, and I think you see that. We know the mask wearing has become kind of a political identity marker in some areas, and I think that it's safe to say that that's the way it is here as well. One of the October school board meetings, I believe it was October, might have been September, had to be ended early because the crowd became so unruly that they had to shut down the meeting. And then the school board got special training in Robert's Rules of Order so that they hopefully could keep more order in the next meeting, which I believe was just virtually. So this may be, this one they did offer an in-person option, but I know there were a couple meetings where they only offered them virtually for a while, I think, so that they could get their ducks in a row. So yeah, it's definitely become a bit of the that sticking point where people are really passionate about what they think they need to do to keep their kids safest.
Your daughter or son is troubled by that? Okay with that? Wears the mask and
she's totally fine. I mean, she's been wearing them. She did part-time in-person kindergarten last year in Blacksburg, and she's now in first grade here and wears a mask with no complaint all day.
So I know this because you put it on Twitter. You need to tell the story about her vaccine.
Oh yes, she got vaccinated on Saturday. We're very excited about it. She thought that the vaccine would hurt, in her terms, 1 decillion times. She had built it up to be a very big deal in her mind. There was much wailing, much wailing and gnashing of teeth. But after the shot, she said she barely felt it. She said it only hurt this much. So anyone watching, you can pass this along to your children. It apparently did not hurt much at all. And then she didn't have any side effects at all and proceeded to tell people that even though her mom and dad got sick from their shots, she didn't get sick at all. So she got a sense of moral superiority out of that, I think.
Well done. First graders out there listening, as well as parents, you heard it here. Thank you for that, Catherine. Really appreciate that
yeah,
update.
Absolutely.
And Tom, let me bring you in. Where are you calling from and how's it looking there?
So I'm in Blacksburg, where the main Virginia Tech campus is, which is a university town in a fairly rural part of Southwest Virginia. I taught virtually all of last year. My classes were all online, which is the case for the vast majority of Virginia Tech courses. Although students were back on campus, but they were mostly doing online courses with a few exceptions. This fall, where most courses are in person. So I started teaching in August wearing a mask, and have been doing so consistently. The university is more open, certainly, than it was last year, but there's still quite a few people working either full-time remotely or at least some of the time. So it definitely has a different feel to it. We do have a university mandate to wear masks in all indoor spaces, and that's mostly been enforced. My daughter graduated from high school a few years ago, so I don't track the school system with quite the same level of personal connections that I used to. But as Katie knows, there were issues here. This Blacksburg is part of a county school system, and several of the schools in the county are much more rural. And so there have been differences within the system between parents and teachers and administrators over the necessity for masks and so on. It's still, after a year and a half, it still makes me pause when I see children lined up for the bus wearing masks. There's just something that makes me think, wait, that's not right. Oh, wait, that's what they're doing. And I very much appreciate you reading that New York Times story. I think part of what, and this is the reason I asked Catherine about her daughter. We all have a personal trajectory in this pandemic. And you reading the story from May of 2020. I'm remembering where we were in May of 2020, in terms of the disease, but then also where we were in 2018 with the centennial of 1918, and then what was happening in Vermont in October of 1918, and so I think on some level, we are all historians now of COVID, we're all doing what historians do, which is try and make sense not only of what's going on right now, but what just happened to us.
Yeah, I was really one thing. I'm glad you enjoyed that story. Maybe we'll talk about it more. But the fact that this man felt that it was also about not just about the disease and the big number, but it was about his grandfather. I mean, it was about a small number, but the most important one for him. And I think that's where this sort of constant problem of quantification, it's not a new problem in pandemic, plays in, because past a certain number, it's hard for people to retain an emotional attachment to the disaster. There's one thing, just before the moment passes, Tom, I wanted to ask you, and Katie, if you wanted to come in on this as well. We don't have to break down the whole governor's race in Virginia. However, from a distance, it was hard for me to see how much COVID played in that campaign. It looked like it wasn't very much, or at least from my vantage point, it wasn't what I thought. And I see it as a kind of a precursor of coming governor's races and other, national level political events on the horizon. I'm sort of trying to get the measure of how much COVID is going to play into that. I don't know, Tom, would you mind sharing your take on that?
Sure. I agree with you. I think if you were to do any kind of a list of what got the most attention in the media, certainly the exit polls, what people were talking about, COVID in and of itself was not high on the list, and certainly over the last year and a half, Virginia has not had the divisions over COVID response that we've seen in other states. The governor in Virginia is a medical doctor, and he was pretty consistent in following the CDC guidelines and not necessarily following the position of the Trump administration in a way that a lot of other governors, particularly in the Southeast and Midwest and mountain states, did. So I think that kind of removed the issue as a political one. The Democrats couldn't really run on Northam's record, and the Republicans didn't really attack it. I would say where it really was an issue are in the kind of secondary effects. So the economy, and the issues around labor shortages, the supply of goods, fuel prices. There was almost no discussion of the benefits, the child tax benefits and all these other things that came from the Biden administration. But I do think there was a kind of sense of weariness of being having put up with a difficult situation for a long time, the uncertainty of it, and also, just to go back to the earlier topic, the school systems and the school boards and the dissatisfaction with remote schooling and the allegations of unresponsive school boards and teachers unions, which in Virginia is kind of hilarious because they don't have a union. So I think it was a secondary effect. And I would say going forward, that's going to be one of the questions, that if a year from now or 11 months from now, there's still this sense of pandemic fatigue, I think that will be a real issue. And to go back to our historical comparisons, that certainly wasn't the case in 1918, 1919. There was much more sense, we turn the corner, everything's behind us, we're moving on. And there have been a couple moments in the last year and a half when I thought we were at that point. We're kind of there, moving there maybe now, but we've been disappointed before, and thinking, if you go back to this past spring, when the vaccines were widely available and there were, there's discussions of changing the mask regulations and other things. And then we had the Delta variant and people refusing to get vaccinated and so on, so I think that to me becomes the question. How much more, not only do people put up with these requirements and these limits, but at what point does their general dissatisfaction turn into a more political position?
Catherine, I thank you for that, Tom. I don't know if you wanted to add anything onto that, Catherine, or your own sense of what you saw playing out in this last campaign. Is it a bellwether for things to come, do you think?
I was surprised that it wasn't more of an overt talking point. Just going back off of like what gets airtime in media, local and national. But I think Tom's right that it was there implicitly as far as the people are tired, people are burned out. I also think, that was overshadowed by kind of the panic, the moral panic around like CRT and trans bathroom panic and that kind of thing. And I think the similar talking points come up in all those issues, right? Where people feel like, and this is again kind of through the lens of the school board and the schools, where people are seeing certain actions as a form of repressing themselves or their children. And that we got that messaging a lot, especially when like in the early days of masking. I mean, especially, even now, but where the idea of covering your face for a public health benefit was an act of government overreach or an act of repression. And so I think that kind of sentiment came out in these other issues as well that maybe came to the forefront. So I don't know if it'll be like explicitly how people responded to COVID will become the political talking point, but I think that kind of a priority or that talking point will be similar in terms of what people are expected to sacrifice for public good or what the government can and can't tell you to do. And that's not new, but the pandemic fed that, I think, in maybe not a new way, but kind of like a new for 2020 kind of way.
There's one other thing I wanted to talk about before I ask you about your articles and other recent research, which is actually just the question I've been asking everybody about how they remember this pandemic. And Catherine, let me ask you that question first. Is there a memory, something that really sticks in your mind of this time period?
Yeah, and it's one that makes me look bad, but I'll tell it anyway because it fits into our conversation. So very early on, I had a friend, and it was one of those things where it was like her sister-in-law's brother works at the CDC or something, and this was maybe around February. And she was telling me, and she was like, this COVID thing it's going to be bad. They're going to need to close schools, and we may need to start stocking up on certain supplies, toilet paper, food. And I laughed and I said, that's absurd. Like, that's not going to happen. And she was like, yeah, they're saying it could be as bad as the Spanish flu. And I was like, there are multiple factors that made the Spanish flu so bad. The movement of troops, right? The shortages of medical professionals because of the war. Like, there were multiple factors. We know way too much now to replicate the conditions of the Spanish flu. And I have since apologized, obviously, to that friend and been like, you were absolutely right. And your informant obviously knew much more than I did. And I think of that moment often, especially when we passed the mortality or the estimated mortality numbers for the Spanish flu, last month? And I thought about that moment and me being so confident that is not something that we could expect with this. But here we are.
So thank you for sharing that. I don't think that makes you look bad at all. I think the fact that you knew the historical analog and felt like we would meet the moment with some rooting in history seems pretty rational to me. And I made similar kinds of announcements at the time as well, including eschewing wearing a mask because my brother told me that I shouldn't. And very early, like in February, and I said, yeah, and the peer pressure from my brother forced me to put my mask in my bag. And then, I've kept a dialogue going for a couple of months after that about who was right and who was wrong. Because of course the CDC was saying something. I'm still trying to defend my position. You see, it's still an issue for me.
Yes, of course. Well, the CDC did make a very abrupt about face with mask wearing. What got me was they had just turned the corner on recommending masks. And I walked into Aldi in the town next to Blacksburg, and everyone else in the store was wearing some sort of makeshift, bandanas or shirts or something. And I had walked in with a bare face, and I remember being very embarrassed. And I was like, "Oh, I can't do this again." And that was my turning point for mask wearing.
Those stories from the early pandemic. Thank you for sharing that. And they seem like they do come from such a different time. Tom, same question to you. Do you mind sharing a personal memory?
Yeah, no, I also have examples like yours and Catherine's of mistakes and underestimating and all the rest of it. I think for me, it's the personal losses in this pandemic. Some of which did affect me, but I think it's also an appreciation for healthcare workers. What they went through, particularly in the early stages, people who take care of in childcare centers or elder care, and I think it fundamentally changes the way I think about the history. Also, having experienced this now, and so for me, that's what I think I will remember going forward. How this came directly into our lives in a way we didn't expect. I think it's a little unusual because of the work I do. So much of my interactions with people have been on this platform electronically, and so that's the other piece that I think I probably always will associate with this pandemic, is this kind of interface and the distance, you have between people. I remember the version of what you said, Catherine, the first time I went back into a store after not going into a store for weeks, and having that level of anxiety about being close to people, and at that point, this would have been, well, like that article, this probably was April 2020. At that point, people were wearing masks, but just feeling like I don't want to be close to people. I like I'm going the other direction in the aisle, and I think that almost sort of visceral, physical kind of memory. I think that's what I hope I keep from this experience.
Just to follow up quickly, Tom, just kind of a historian's question. So one thing you said there really struck me. You think you'll read the sources from the 19th century and the early 20th century differently now?
Yeah, I do already. Yeah. And I think but in two ways. I think I'm more attentive to the stories, the people that were affected, and kind of again having that sense of empathy from what we've seen around us for the last year and a half, and then appreciating what that was like in the context of a historical epidemic. I think it's similar to what military historians have done, and the kind of ability to think in terms of what's the life like on the battlefield, and then how do you try and convey that. The place that's really shifted for me is actually thinking about public health experts in the context of an epidemic. And I think that's generally true of the way people study 1918. The Alfred Crosby's book was mentioned in that New York Times article, and Nancy Bristow. And if you haven't had Nancy Bristow on this COVID conversations, you should. She's fabulous. But I think that generally historians, when they looked at 1918 up until 2 years ago, were pretty skeptical of public health experts. They really think they got it wrong. They thought they misjudged the pandemic. They acted too late. They didn't do enough. They were inconsistent. And having been through this, I have a lot more empathy for them. They were dealing with a very unprecedented, complicated, confusing situation, and they made mistakes. But I think I've become more attentive to, what were they thinking at the time? Why did this make sense to them as a decision? Rather than sort of stepping back and saying, well, look how bad it got. They must have done something wrong, which doesn't keep me from being very critical of what our own public health system has done, last 2 years.
Just this hits a note that is resonant with my call yesterday with Saloni Bauman, who's a graduate student at Yale. She's working on HIV/AIDS and the welfare system in the United States. And she said something very similar, Tom, that I asked her how the pandemic makes her think about the work differently if it does. And she said exactly, she reads those letters, particularly the early activists around HIV/AIDS. Not that she wasn't empathetic to them before. I'm not doing her total justice. You should watch yesterday's program. It's great how she describes it, but she has a better sense of what they were up against than she did before, because now she's lived lived through this. Just want to remind everyone that you're listening to COVID Calls. I'm talking to Catherine Randall and Tom Ewing today, and I want to turn to one of your projects, the article "How Did We Get Here? What are droplets and aerosols, and how far do they go?" which appeared in Interface Focus just last month. And Catherine, maybe I can turn to you first on this. I'm just going to read a sentence here to set up some of what you're talking about in the article. Maybe you can tell us what the goals were with this piece. It's really, really in-depth and wonderful piece, and I'll put up the links so everybody can find it. But you write, the COVID-19 pandemic has exposed major gaps in our understanding of respiratory disease transmission through the air. These gaps led to heterogeneous and shifting transmission mitigation policies from governments and public health organizations. We were kind of talking about that just a second ago. Catherine, why did you all set out to write this piece, and what are the main objectives of it?
Well, the initial goal of the piece, I guess the problem motivating that article was that you had multiple groups of experts talking past each other, basically. You had public health folks saying, oh, the COVID is transmitted through droplets, which is close contact infection, right? And we have these social distancing guidelines saying if you stay 6 feet apart from someone, right, that's droplets fall before they get to 6 feet so that it won't land on your mucous membranes and you won't get infected. And then you had aerosol scientists saying, from the very early days of the pandemic, saying, we're getting some emerging data indicating that this is not transmitted by droplets. This is aerosolized. This is airborne. There was a study that one of our co-authors, Jose Jimenez, did where there was like a choir in a room, and they all stood more than 6 feet apart, but they still were able to infect each other. So there was emerging data showing that this is airborne, and scientists becoming increasingly frustrated with organizations like the WHO and the CDC, who kept saying this is not airborne, this is droplets, because they were seeing the science and seeing that these particles were aerosolized. And so and one of the reasons why Tom and I were brought on board to this project is because our co-authors in the sciences were wondering like where this discrepancy came from. They were saying, you know, what is the reluctance basically from these public health organizations to classify this as airborne when we're seeing that these particles can stay in the air. And public health information says, you know, anything under 5 microns in size is considered an aerosol. Anything over 5 microns in size is considered a droplet. And they were wondering where that distinction came from. Basically, where did we get this distinction between a droplet-based infection or an airborne-based infection? And what are the implications of making that kind of division when we're determining how to implement public health measures and infection protocols for COVID? So that was the main goal, basically, was to show that there is a historical basis in these terms and in this understanding. And so we did this historical tracing of these sources, working from the infection guidelines from these public health organizations, tracing back their citations. Who did they cite? Where are they getting these definitions from? To show that what the understanding of what we consider airborne has shifted over time, and different groups have used that term in different ways. And that may be part of the reason why these groups are talking past each other, because they have different understandings of what we consider to be an aerosol and what we consider to what sizes of particles we think stay in the air, and is that airborne or is it not, or different definitions for that word.
I see. And I should mention your co-authors, Elsie Marr, J.L. Jimenez, and El Barouiba. So this is a multi-author project, and thanks for setting the stage for it. I mean, what a unique coming together of scholars, and you and Tom were brought in for the historical dimension. Tom, so tell us a little bit more about how this kind of debate plays out in the 19th century. And I guess also, like, what did you think when you got the email, or maybe you know these people very well, and they said, we need some historians on this stat?
That is exactly the email I got. I've waited my entire professional life for that email. I had worked with Dr. Lindsay Marr, previously. I'd hosted a summer seminar funded by the National Endowment for the Humanities for K-12 teachers on the 1918 flu, and the teachers had gone into Lindsay's lab, and she talked to them about her research. So this was 5 years ago. But once I mean, the question was, as you'll recall, in February and March of 2020, and Catherine just explained this, how is this disease transmitted, and the implications of that for what can we do to prevent the spread. And so Dr. Marr, was really with her colleagues and the others beyond the ones in this article, had really been pushing this different position, as Catherine just explained, that it was done through aerosols, and therefore the containment, the mitigation measures are different. Masks work the same way, but in terms of social distancing inside, and particularly ventilation, is much more important if you recognize that it's being transmitted by aerosols. And so, they were really involved in an advocacy position. But what interested me when in the email from Dr. Marr, and the reason I immediately suggested Catherine as a collaborator, was the kind of question that they were asking is, how did this orthodoxy, this kind of accepted wisdom, not only become so settled in the field, but without ever questioning how it came to be, why it is this way? I mean, they were talking about, textbooks in environmental engineering that go back decades that just stated, this is the size of the droplet and this is the size of the aerosol. And because Catherine and I had worked together on a volume that was called Viral Networks, she had spent a lot of time looking at citation networks, how scholars refer to each other. And so that was the historian's, kind of approach. Like, okay, if they cite this person, go back and see who they cite, and go back and see who they cite, and try. And that's basically what Katie spent a lot of the summer trying to sort through. And I think what interested me, and the only part of the article I contributed, was that early in the 1918 pandemic, there was the same confusion. There was the same uncertainty. How do we explain how this disease is transmitted? And they actually use some of the same images and some of the same metaphors. When you cough, this is where your breath goes. This is where the droplets go. If you're standing this close, you're going to be infected. If you put a handkerchief over your mouth or you cough into your sleeve, that's not going to happen. But they also talked about aerosol. They didn't use aerosol as a word, but they understood it could be transmitted through the air because of the research on tuberculosis, and they were aware of these other mechanisms for transmitting disease, and I think that's where watching Dr. Marr, Dr. Jimenez, and others, try and convince people to think a different way about this science because of the implications for public health. I was very interested in contributing to that, and yes, there was an email, and I, replied and said, "This is the person you need to talk to, because she's an expert. She's very good at kind of figuring this out." And I think that it's there was over the course of the summer of 2020, Dr. Marr, was part of a session hosted by the National Academy of Science, Engineering, and Medicine with Dr. Fauci and others in the audience, and they persuaded them to think differently about this disease and the way they were communicating the risk. And part of that was, thinking differently about the history and the way that this kind of accepted wisdom had been so settled, and yet really wasn't. It was based on a series of kind of misconceptions and miscitations, and maybe they didn't do the entire reading. They just read the abstract. Catherine has a better sense of that than I do.
Yeah.
Catherine, so you were Tony Fauci's in the audience and you have to tell him that he's been relying on his network too much and hasn't gone back and done the reading he needed to do. That's a tall order.
It's a big ask, right? Yeah. To kind of build on what Tom was saying, my PhD is in rhetoric and writing. So not history, but part of my training in rhetoric of science and medicine, where my research focuses, is looking at these ideas about science and medicine, and looking at how things became these kind of like the settled science or this kind of settled idea. And like Tom was saying, this tracing back of going back to the early 20th century and these ideas about airborne infection, like you said, there are a lot of the same sort of resistance to the idea that something could be airborne. In the early 20th century, they were making a lot of inroads into public hygiene. They had, they were purifying water, they were sanitizing surfaces, and it was going so well. And the idea of bad air, and this is one of the big kickers right at the time. The idea of bad air was like old. That's like miasma theory. We're in germ theory now. Miasma theory is old fashioned, and we don't want to if we say that the air is bad, that's like putting science back 40 years. So there was a lot of professional reluctance. I won't say a lot, but there was a professional reluctance to embrace the idea that the air, there could still be something in the air that was bad. And so we saw that kind of persuasion trying to happen in the scientific community from, the 1920s all the way up to the 1950s and 60s, until finally you had researchers able to kind of prove definitively that tuberculosis is transmitted through the air. And there was no other way that those guinea pigs could have gotten it. It just had to be our study, and we just did it through airborne infection. And that was really the first disease you had where it was like, okay, the scientific community accepts that this is like airborne. But that was 40 years of researchers sort of like doggedly pursuing this idea of like persuading the public health community that this is like these diseases could be airborne: measles, tuberculosis, chickenpox, that kind of thing.
So just to stay with this for a second, because one of the parts of the piece that was really fascinating is the 5 micron threshold.
Yeah.
And so why does that get so stuck? And I guess, just to say a little bit more, is it that an infectious disease can exist both in droplets and in aerosol, and so it's a sort of both and kind of situation, and you need to take you need to have the mask, but you also need to be thinking about ventilation, because that seems to be part of the COVID messaging problem, was that it was an either or kind of thing, particularly of thinking about last summer. So I guess any part of that, Katie, you want to pick up, but that the history of science really shows us time and again in public health, when a standard gets settled, and particularly if the public, or when the sort of outer rings of the public health, officialdom understands it and can message it clearly, it's hard to move people off of that.
Yes. As we've seen, public health messaging, especially during a crisis, it's really difficult, especially when the science, you're discovering things about COVID in real time, and you're having to shift the messaging in real time. And I think last summer we saw that the CDC lost a lot of public trust. Because of the inconsistency in messaging, or because like we had talked about already, that very firm, like, you don't need masks don't help. And then a few weeks later saying, just kidding, actually, we do want you to wear a mask. And the idea that they had to have a settled idea of what it was and what the guidance could be, instead of maybe taking a more, an approach that embraced the kind of the messiness of the scientific discovery. But yeah, I think one of the things that prompted the piece was that very kind of rigid distinction between droplet and an aerosol, and the idea that, and I heard this from people in my circle. They're like, well, if it's airborne, then masks are unnecessary. We don't need them. And if it's droplet, then we don't need to stay. We don't need social distancing, and we don't need filtration systems and stuff, because we can just wear masks and that'll be fine. So there was, I heard a lot of kind of comments to that effect. But that 5 micron thing, going back to tuberculosis, what you see in the historical tracing these citations back is that there are different meanings and understandings of the word airborne. Certain early researchers in the 1930s said, well, it's airborne because it stays in the air. And that's what we're considering the marker of what could be airborne infection, is that a droplet carries, or a particle from your face carries that infectious particle, or some sort of liquid from your face carries the infectious particle, and it stays in the air. And you might, and that's what airborne is. And then there were respiratory, industrial scientists and respiratory scientists that started talking about airborne as what could be inhaled. And they said, okay, well, there's a different size now. This size of particle stays in the air, but only this size is small enough to be inhaled. And so then you had a whole field of people talking about airborne as being respirable. And then with tuberculosis, you suddenly have researchers talking about what size of particle is infectious. And with tuberculosis, infection, what causes that disease, it starts in the very bottom of your lungs, right? And in order to get down that far, the particles have to be between 1 and 5 microns in size. And so since tuberculosis had that study where it was determined to be, or kind of publicly understood as the first verifiably airborne disease, the pathogenesis of tuberculosis then became the sort of benchmark of any sort of airborne pathogenesis, where that became what we consider the infectious standard. So then we've moved from, okay, airborne is what stays in the air, airborne is what is respirable, and now airborne is what is infectious, but we're actually measuring that against what is infectious for tuberculosis. And so you have researchers now saying, just because that's how it was for tuberculosis does not mean that there aren't larger particles of other diseases that can't be infectious in other sizes. And so that size is based on what we understand about one disease and kind of the conflating of those definitions, but may not be applicable to what we're seeing now. So that's sort of like where that size distinction came from, and that rigidity around that size distinction. And that was one of the outcomes of our article. We were hoping would be to challenge that by showing that it had a historical origin that was not necessarily based in robust studies of all these different illnesses, and really came out of this historical understanding and these different fields talking about these things in different ways.
It's a remarkable piece of historical sleuthing. Thank you for explaining that, Tom. If anything you wanted to add to it, and I'm also interested in the sort of how the history of biological warfare plays into this, or the history also of context coming back to World War I, and battlefield, aerosolized battlefield inhalants as a weapon of war is also part of the background, I guess, context of this as well.
Yeah, no, I mean, Catherine did a great job of explaining that. There is one connection with 1918 and what you just mentioned in terms of weapons. And I think it's interesting to go back to something we were discussing earlier about kind of messaging on the disease and public health measures. World War I obviously is where poison gas was used as a weapon, by all sides, and it had a devastating impact on soldiers. There are rumors early in the pandemic in the United States that the germs had been unleashed by submarines, German submarines off the coast of I think New York and New Jersey. And those get picked up and reported almost verbatim by a bunch of newspapers within a week or so. But then just a week or two later, the War Department denies that. They say, look, we researched this. There's no evidence, that this disease was spread by Germans. It came on boats. It spread, from person to person, just like other diseases. And then those rumors go away. I found no evidence that they come back. And this came up again, obviously, with all the discussion about, these efforts to find the origin of the virus in Wuhan, and did it come from a lab leak, and the implications of that. And I think it's really striking in terms of what Catherine just said, which is, even during a war. I mean, this was September 1918, October 1918. The United States was still at war with the Germans at a time when there is, ferocious anti-German propaganda, efforts to mobilize the people against this enemy. It was like there was a line there they didn't want to cross. They could have exploited these rumors. And I don't have archival evidence, that there was any discussion of this, but my sense is, there may have been this fear that if we start using these rumors and spreading these rumors, then we don't know what people will believe anymore. They may not believe us if we make these other recommendations. And I think that's something we've really been obviously struggling with for the last year and a half. There's so much good science out there. There's so much documentation. There's so much explanation. And yet people will seize on uncertainty or changes or miscommunication, like the mask recommendations early on, and then, kind of hold those up and say, look, they don't know what they're talking about. They gave us bad information. They retracted it. Why should we believe them now? They were wrong before. And it's been terribly destructive. We're seeing this now with, the misinformation about vaccinations, and despite efforts to, identify each of the pieces of this information and refute them and provide evidence, there are still people who believe them and hold them up. And I think this article was a really kind of interesting exercise in the sense that, on the one hand, even scientists, make mistakes. They repeat things that aren't well substantiated, and they repeat those. But people who have challenged that and to provide a different explanation can be persuasive, in leading to a new understanding of these really important issues.
I think that this is really, I want to follow up on that. The public health communication and risk communication generally, I don't think it necessarily says that an expert can't be wrong, but it has to do with sort of communities of trust, and it has to do with also how they explain when they're wrong, that it's not, therefore, it shouldn't mean that they're completely deplatformed forever, but that they're engaged in a learning process. And there's a certain level of kind of humility that's required of the communicator to explain that they're learning, and you're learning. It's a vast literature. I can't characterize it all at once, but I think I'm sort of curious about how that played out in 1918, 1919. Tom, let me just stay with you on this, and then Katie will bring you in too, because misinformation is one thing because of maybe scientific misunderstanding. And so I'm curious about, how that played into communication efforts during 1918. But what we've seen, and what you were just alluding to, Tom, is disinformation and conspiracy thinking, which has been weaponized either for a profit motive, usually, I think, to sell ivermectin, or for political gain, which may have seemed like a kind of a moonshot. Like if we tell people this thing and we get enough to believe it, I can get elected on that. That seems crazy. Well, that's not a crazy proposition, I don't think, in American electoral politics anymore. I don't know if you just saw that one of America's so-called frontline doctors, the ones who were pushing hydroxy early in the pandemic and have been against vaccination, has now been named Surgeon General of the state of Florida. So those are not only is misinformation not disqualifying anymore, it's actually what's required on your CV to be named to certain political positions. So I guess I'm sort of reaching for analogs across that time stretch there, and wondering, I guess, to put it in a more basic question, were there conspiracy charlatans in 1918, Tom, who found gain from that?
The most it's a great question, and I obviously have been thinking a lot about this for the last year and a half. I would say the most blatant charlatans in 1918 were actually the anti-alcohol lobby, the prohibitionists, who were doing great. A lot of states had already adopted prohibition. They were on their way to ratifying 18th Amendment. It's the 18th. That one that secures prohibition. But they seized on the epidemic because closing bars and saloons was one of the public health measures. I mean, they closed basically any gathering area. So schools were closed, churches couldn't have services, restaurants were closed, but bars and saloons were a major gathering area. And the prohibitionists, the temperance movement just jumped all over that, and they came up with all kinds of really far-fetched kind of explanations that the influenza was associated with excessive drinking and alcohol consumption and socializing. And a lot of that had to do with class and gender and anti-German sentiments and so on. The alcohol lobby, of course, argued that liquor was a cure for influenza. So they had their own issues. But generally speaking, in 1918, you do not have the political divisions, that we saw in 2020 and 2021. There were disagreements about the right kind of public health measures, but usually they were either jurisdictional, so the state had one view and the city had a different, or the city health department had one view and the business owners had a different, school boards had one view, city government had a different view. And they usually explained why they were making the arguments they were doing. And so other than, for example, like I said, that U-boat example is really one of the few where you can kind of say there was this possibility of a kind of organized misinformation campaign, and it got stopped. It didn't really get this circulation. I mean, there were definitely quacks. There were all kinds of cures being marketed for influenza. Vicks Vapor Rub does great during the epidemic by claiming it's a preventative for influenza. So I think you always have that. Those commercial interests trying to take advantage of the fear around the disease and so on, but not the kind of deliberate, willful disbelief of authorities because of a particular political perspective.
Katie, did you want to comment on any part of that?
Yeah, when you think about the channels of information now, the oral transmission of information has a very long and storied history, right? And that stuff doesn't get written down in ways that we would have access to them now. So certainly there could have been disinformation spread that way, but when you think about like official channels of information, much more limited then than now, as in terms of we have social media, we have a variety of news channels and websites and all sorts of places you can find things outside of like the official numbers published in the newspaper, right? Or a blurb from a doctor that goes out in a number of periodicals. And Tom knows more about that than I do, but just on the communication side, like our communication landscape is just vastly different than it was 100 years ago. And I think we're still a little bit confused by that. Like we're not really sure. There's this idea that if you just present the facts you just tell, here are the facts, here's the data, that people will say, oh, well, I'm convinced. That is excellent. And now I know what I can do. But that's not how people work. People are persuaded by their values and their priorities, their identities. And you're absolutely right, Scott, in terms of risk communication, right? I think we saw a lot last year that people were they thought that if they admitted that they had done something wrong or said something wrong, that they would lose authority. And they thought that was the most important thing in that communication process, instead of focusing on what would build trust, like you said. And so people turned to other sources of information that validated their fears in different ways. And they said, well, I feel like I can trust this source and not what's coming from Fauci or what have you.
Listening to you talk, thank you for that, Katie, that makes me wonder. This is historical malpractice, what I'm about to say, but that one wonders a scenario in which you had a Facebook or social media in 1918, how that, because this is the independent variable here, the social media and other forms of communication that you're exploring a little bit here, Katie, is a really powerful way to think about that. And it's an important way to think about disaster more generally. Oftentimes we say, well, what is the event that happened? Let's focus on the rainfall totals, or let's focus on the understanding the source, where's patient zero, instead of thinking more broadly about the everyday aspects of life. How do we communicate? Whom do we trust? Where do we get medical information? And those for most people, those are the boring parts because they're used to them. They're not exotic in any way. They're not cinematic. It's just Facebook. But what we've seen is that those vulnerabilities in those systems are the exact ones that have allowed COVID, at least, to run rampant in the United States.
Yeah. And, there are researchers that focus on digital communication practices and social media. And that's kind of outside of my lane there. But it's been interesting. I just kind of casually looking through the Facebook groups about ivermectin and where to get it and where to buy it. And because I'm so interested by what motivates people to this kind of solution. And they're not eschewing medical authority. Like, a lot of folks in those groups are saying, well, my cousin is a doctor, or I'm a nurse and I say this works. And so they're still appealing to medical authority. It's just completely outside of that kind of official communication channel that maybe they feel that they can trust less, which I think is really interesting.
You're listening to COVID Calls, and I'm talking to Catherine Randall and Tom Ewing. My guests have very kindly agreed to stay a few more minutes. Really enjoyed this conversation. There's another part of it I wanted to get to. Tom, you've been extremely active also in writing about the pandemic as a way to approach history. You published a couple of articles. You did one for NEH. On using history, the last pandemic, using history to guide us in the difficult present. So, this is for the history teachers who are paying attention, to this conversation. What are some of the highlights from your thinking along those lines, using 1918 as a way to teach COVID, or in a sense, what we've been talking about here today, how to use COVID to excite people's interest to think again about 1918? I'd like to hear your thoughts on that.
Yeah, well, you mentioned history teachers. I have to thank teachers for everything they've done for the last year. I was about 30 minutes into my first in-person class wearing a mask and thought, oh my, like, these people did it all year. Yeah, and I think this was, like, as I think I mentioned, I hosted 2 NEH seminars for K-12 teachers, National Endowment for the Humanities. And in both of those seminars, we went up to Bethesda, Maryland, and met with scientists from the National Institute of Allergy and Infectious Diseases, David Morris, science advisor to Dr. Fauci, and Jeffrey Taubenberger, who coordinates the vaccine research on influenza for the virology lab, and I'm remembering in both of their presentations, the question came up, could the Spanish flu happen again? And they were quite confident that it wouldn't, that there were, first of all, there's enough vaccine, there's enough known about vaccines, enough people get vaccines, that there would not be sufficient exposure and infection to generate that. And there are antibiotics, there are ways to treat the bacterial pneumonia that caused a lot of the deaths in 1918. And it wouldn't happen, that yes, there could be a severe influenza, and particularly an influenza that was not, prevented well by the particular type of vaccine we had that year. But I in thinking back, I'm like, gosh, they were pretty optimistic, and I'm wondering what they would say now. So I think that's certainly one part of it, in terms of thinking about this pandemic and thinking about historical pandemics, is on the one hand, we need to be a whole lot more modest and realistic about what we think is going to happen and what we predict is going to happen. But I think also appreciative of what we can learn, from this history and going forward. I think, starting in February 2020, people started asking me, you studied 1918, like, what can we learn from that? And it's interesting because the answer I gave then, I think, has been pretty consistently the answer I've given, which is listen to public health experts, but understand why they're saying what they're saying and what they're recommending, which I think is different, I hope, from listen to public health experts and do what they say. We saw with Catherine, I think really give a really good example of that, where, early on, public health experts were wrong about how the disease is transmitted and the implications of that in terms of social distancing and wearing masks and ventilation and so on. But if you go back and ask, well, why were they making that recommendation at the time? Part of it was not understanding the science, but I think part of it was also like, we need to make this really simple for people. They need to think about not coughing, not sneezing, not breathing on people close to them, wearing masks, staying apart. And so the kind of introducing aerosol transmission would have further complicated that. It would have been harder for people to understand what they needed to do. There was a lot of bad information at that time. I mean, every time I go in a store and I see the 6 feet markers, like, no, that's not how it works. All of the plexiglass shields that were put up that don't prevent any kind of aerosol transmission. So I think, to me, it's like, think about what you're being asked to do, think about why you're being asked to do it, and then also why you need to do these things, not so much for your own health, but for the health of everybody else. And I think that was a message in 1918, and I hope it's been a consistent message now. I mean, I go back to December of 2020, January 2021, when, we knew the vaccines worked. They were starting to be rolled out. I was keeping track of when my father was getting one, my father-in-law, my mother-in-law, like we all knew, and I'm like, why didn't I understand how resistant people would be to getting vaccinated? Like, that just didn't occur. I mean, I knew there was discussion about it. We knew there was a vaccine resistance and hesitancy in anti-vaxxers, but it just never occurred to me that, 40% of adults would just refuse to do this. And I, completely misunderstood that.
Yeah, I think one of the things we'll have to address going forward, and I think that we see this historically and in the contemporary moment, is getting past the idea that illness is tied to morality. We've seen this in multiple pandemics. I'm a healthy, good person, I don't need to wear a mask. We saw that in the early 20th century, where the idea of being a vector of disease was associated with being unclean or not white or not rich, right? And so rich white folks were like, I can't be sick. I can't get people sick. And I think we saw that last year as well, from political leaders, and kind of that trickling down of, I don't need to wear a mask because I'm not a safety concern. I would not put my children in danger. I would not put my friends or my communities in danger. I'm not sick. I'm not unclean. And, Scott, that goes back to that article you were reading about the war, and thinking about why World War I got this, like, the memorials and the recognition, whereas the flu and all these deaths didn't, right? Disease, and we see this with modern warfare, right? We don't have the clean cut World War I, World War II, we won, party in the street. It's not quite the same now, and it's much messier. But I think the idea of illness, and the idea that all those deaths happened not because you went to fight a very clear bad guy and your troops died honorably, right? It's more like friendly fire, right? This transmitted through our communities, and there wasn't a person that we could kind of take out to stop it, right? It was us, and it was our communities and our folks. And I think that makes the whole thing much more difficult to process. And like Tom, I don't think I would have understood that as well had I not lived through it. And I see people's reluctance to even deal with those numbers and process the severity of what's happened. And they still are resistant to public health measures to prevent increased spread. And so I think we don't want to think of ourselves as people, as We want there to be a clear story, and we get that with these earlier wars, and we don't get that with pandemics. And how do you memorialize that, right? What's the story? Where's the victory? And how do you talk about all those deaths without talking about how you failed and how your community failed? And that's really hard. And I think we're going to run into the same problem with COVID. I don't think we're going to have, we're not going to have the reading of the names like we do for 9/11, right? We're not going to read the lists of victims from COVID. I don't think we'll do that.
That was that's where I wanted to kind of bring us full circle. Catherine, you completely anticipated what I wanted to ask you, that stretch across time of the absence of the 1918 memorials and where that leaves us today. I'm deeply disturbed by that, in part because I think memorials play an important role in healing, in closure, and in healing and sense making in the moment, but also because they should be a sentinel for future generations, for people to stop and think that something is unthinkable has actually happened, and that maybe they can percolate some thoughts about that as they go in their daily lives. I think you've drawn a really nice sort of arc there. It's not a particularly hopeful one, but I appreciate your honesty. Yeah, Tom, your thoughts on what are you there in the same camp with Katie on that, and memorials across 1918 to the present?
Yeah, I mean, I think there are actually a lot of memorials to victims of the 1918 Spanish flu. They're just not identified that way. If you look at any list of soldiers who died in World War I, my guess is that anywhere from a quarter to half of them are going to be victims of the Spanish flu. They're just not identified that way. We have a memorial here on campus. I was just talking about with my class, 13 of the 26 names, well, 6 for sure, died of the flu, and so they're there. They're just not recognized in that way because they're folded into, men who fought in the war, who died in the war, who are memorialized in that way. You mentioned the previous episode on the HIV/AIDS. Certainly for someone of my generation, the AIDS quilt was a major kind of event because, not only did it put names to victims, but the physical display of the number of names, each of them having a square on this quilt, which was laid out on the National Mall, really kind of brought, I think, out how the impact of this epidemic. And there was an exhibit a few weeks ago on the National Mall, one white flag for all of at that point, I think 680,000 victims. I don't think it had the same impact as the AIDS quilt. It just doesn't get people to think about the effect on this, both quantitative terms, but also individually. And it does concern me. I think that I very much agree with Catherine. The lesson from this is, what do we remember and what do we do differently in these situations going forward? Because there will be more of them.
I'll get a chance to talk about that issue tomorrow. Tom, I'm going to have Suzanne Furstenberg, who's the creator of the memorial you just mentioned in the National Mall.
Cool.
And so I think she's an artist, and she's very reflective on the impact that can have or not have. And these are some of the issues we'll be talking about tomorrow. So thank you you both are anticipating everything I need to say next, which is great. So we're out of time. In fact, I've been very greedy with my guest time today, but I've learned a lot, and I want to thank Tom Ewing and Catherine Randall for the work you're doing, for the huge outpouring of really complicated and interesting historical and rhetorical work that you're doing in this time, communications history. And everybody can check out their articles. I'll be sure to send those out via Twitter, and let's all retweet and read and teach these articles. And so I want to thank you, Tom, and thank you, Catherine, and remind everybody you've been listening to COVID Calls, and you can catch COVID Calls usually at 6 p.m. Eastern Time on weekdays. And do join me tomorrow at 6 p.m. Eastern Time for Suzanne Furstenberg. Tom and Catherine, thanks a lot.
Thanks so much.
Stay healthy, everybody. We'll see you tomorrow.